1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No for more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, the most dangerous 15 minutes of a human's entire life is, it's that transition from the womb to the delivery room. You are literally looking at this tiny human who just went through a massive, dramatic physiological shift.
Oh, absolutely. And as a nurse in the room, you have to figure out, like, is this weird breathing normal, or are we looking at a full-blown emergency? Right. And usually in medicine, we like precision. I mean, a broken arm on an X-ray is a clear, jagged white line. But obstetric nursing and newborn adaptation specifically, it completely breaks the X-ray machine. It really does. It is the absolute definition of diagnostic muddy waters. And for anyone heading into an OB nursing exam, well, that ambiguity is exactly what makes this material notoriously difficult. Everything changes in minutes. The fetal circulation system flips entirely. Exactly. Lungs that have been filled with fluid for 9 months have to suddenly process air, and the baby's temperature regulation drops from a highly controlled, 98-degree incubator to the stark, cold reality of a delivery room. Which is why today we are giving you the ultimate clinical cheat code to navigate that transition. Consider us like your elite OB nursing mentors. I love that. We are hunting down that high-yield 20% of the material that is going to deliver, honestly, 80% of your exam value. Exactly. We are covering the golden hour, the absolute must-know expected versus concerning findings, priority life-saving nursing actions, and of course, the classic NCLEX-style traps that your instructors just love to set. Because, memorization is a huge exam trap. A tricky prioritization question will easily trip you up if you just rely on flashcards. Oh, 100%. You have to understand the underlying physiology. I mean, the actual mechanical and chemical why behind the clinical findings. That is how you develop safe clinical judgment. Right, because then you'll know exactly what to prioritize, what requires an immediate call to the provider, and what is just a bizarre but entirely expected newborn quirk. So let's unpack this. We have to start with the highest priority physiological adaptations because, well, you cannot assess a newborn's reflexes or skin color if they aren't breathing and warm. You really can't. We're looking at the respiratory and cardiovascular systems right at the exact moment of birth. And in utero, fetal lungs are essentially a fluid-filled sponge, right? Yes, exactly. And that fluid is critical for expected lung growth and development. But the mechanical squeeze of a vaginal delivery, it forces a good portion of that fluid out of the lungs and the upper airway. Right, and then comes the baby's first breath, which is a huge deal. Massive. That initial gasp pulls air into the lungs, inflating the alveoli, those tiny air sacs. And it physically pushes the remaining amniotic fluid into the interstitial spaces where the lymphatic system just, absorbs it. But inflating those tiny air sacs isn't like a one-and-done deal. I mean, every time the baby exhales, those alveoli would just stick together and collapse if they were completely wet and empty. Right. They need a chemical mechanism to stay open, and that mechanism is surfactant. Surfactant. That's a huge test word. Oh, absolutely high yield. It's a lipoprotein that coats the inside of the alveoli, lowering the surface tension. And without adequate surfactant, which, is a massive clinical issue for preterm infants, the lungs basically collapse with every single exhale. Exactly. The baby has to work incredibly hard to pry those air sacs open again with the very next breath, which leads to rapid, severe respiratory distress. So for your exam, you need to know the baseline normal to spot that distress. The high-yield core finding is an expected respiratory rate of 30 to 60 breaths per minute. Yes, 30 to 60. Memorize that. It might be slightly irregular, but that window is your safe zone. And for the cardiovascular side, the expected heart rate is 110 to 160 beats per minute. Right, and the cardiovascular shift that happens alongside that first breath is profound. Because in utero, the baby's blood doesn't even need to go to the lungs for oxygen. The placenta handles all of that. So the fetal circulation uses 3 distinct shunts to bypass the lungs and the liver, right? The ductus arteriosus, the foramen ovale, and the ductus venosus. Exactly. And when the umbilical cord is clamped, systemic vascular resistance just skyrockets. Simultaneously, that first breath of air fills the lungs with oxygen, which radically drops pulmonary vascular resistance.
So the pressure essentially just flips.
It flips completely. The change in pressure, combined with the sudden rush of highly oxygenated blood, forces all three of those shunts to close.
Wow. So blood is now diverted to the lungs to pick up oxygen, creating the adult circulation pattern. I mean, it's a mechanical and chemical masterpiece, but it requires massive energy and oxygen.
It does. Which brings us to the next massive safety priority, and a concept instructors test relentlessly, which is thermoregulation.
Yes, keeping the baby warm. Because newborns lack the muscle development and neurological maturity to shiver. I mean, when adults get cold, our muscles spasm to generate heat. Babies literally cannot do that.
No, they can't. So to maintain their expected temperature range, which, by the way, you should absolutely memorize as 36.5 to 37.5 degrees Celsius.
Or 97.7 to 99.5 degrees Fahrenheit.
Right. They rely on a process called non-shivering thermogenesis. They metabolize a highly vascularized tissue called brown adipose tissue, or brown fat.
And this is deposited in very specific locations during the third trimester, right?
Yeah.
Like around the back, the kidneys, the neck, and the axilla.
Exactly.
Wait, so if the baby has this built-in physiological furnace with the brown fat, why is a cold delivery room such a massive clinical emergency? It sounds like they have a system perfectly designed to handle the cold.
Well, because the metabolic tax of running that furnace is astronomical. Burning brown fat requires oxygen, like massive amounts of oxygen and glucose.
Oh, I see.
Yeah, if a newborn gets cold, they divert their oxygen reserves away from their brain and organs just to generate heat.
So a newborn without enough oxygen, a hypoxic newborn, cannot physically perform non-shivering thermogenesis.
Exactly. They get colder, and the colder they get, the more their body desperately tries to burn fat, demanding oxygen they don't even have. This creates a terrifying, rapid downward spiral of hypothermia, hypoxia, and hypoglycemia.
Wow. It's like trying to heat a house in a blizzard with all the windows wide open. I mean, the cold is rushing in, and your tiny little furnace, the brown fat, is working overtime, burning through all your fuel until the entire system crashes.
That is a perfect analogy. And that brings us to the ultimate exam trap, understanding exactly how babies lose that heat so rapidly right at birth.
Right, because heat loss happens through four mechanisms: conduction, convection, radiation, and evaporation.
And immediately following birth, evaporation is the greatest threat. Think about it. The newborn emerges completely wet, covered in warm amniotic fluid. As that fluid hits the air and evaporates, it pulls heat directly away from the baby's skin.
So if you get a prioritization question asking for the very first nursing action immediately at birth, you are not grabbing a stethoscope to check the heart rate.
No, you are grabbing a warm towel.
Exactly. You dry the newborn vigorously, place them skin to skin with the parent, and cover them with warm blankets. You stop the evaporation, close the windows of that house, and protect the brown fat.
Which is so crucial because drying the baby actually protects their respiratory status by preventing that hypoxic spiral we just talked about.
Okay, so we've secured the airway, the baby's breathing, and they are warm. The nurse's job now shifts to the physical assessment, right? Separating expected newborn weirdness from actual clinical emergencies.
Yes, and let's be honest, newborns do not look like perfectly pink, smooth cherubs. They are squished, they are discolored, and they have strange marks.
Okay, let's tackle the skin first. Say you are examining a newborn a few hours after birth, and their main body is pink, but their hands and feet are completely blue. Students often panic at this and immediately assume the baby is hypoxic.
Oh, that is such common exam bait. The question is baiting you into calling the provider or reaching for oxygen.
Right.
But blue hands and feet is called acrocyanosis, and it is a completely expected finding in the first 24 hours. The newborn's peripheral circulation is just sluggish, and the body prioritizes shunting oxygenated blood to the vital organs in the core.
So what you need to actively hunt for is central cyanosis.
Right.
Blueness around the lips, the mucous membranes, and the torso.
Exactly. Central cyanosis means the core isn't getting oxygen. And if you combine that with a baby making a grunting sound when they exhale, or their nostrils flaring out with every breath.
And the skin between the ribs sucking in, those are retractions.
Yes, that is severe respiratory distress. That requires immediate intervention and reporting.
Okay, so what about jaundice? That's another skin finding where timing really dictates your clinical response.
Yes, timing is everything with jaundice. Newborns are born with an abundance of red blood cells, which break down rapidly after birth, and the byproduct of that breakdown is bilirubin.
Right, and to leave the body, bilirubin has to be conjugated, basically processed, by the liver.
But a newborn's hepatic function is immature. Their liver simply cannot keep up with the volume of bilirubin processing required.
So the unconjugated bilirubin builds up in the tissue, causing the skin to turn yellow.
Exactly. Now, seeing jaundice after the first 24 hours of life is highly expected. We call it physiologic jaundice. It's just a normal function of an immature system catching up.
But if you see jaundice within the first 24 hours of life, that is pathologic jaundice.
Right. It indicates a rapid, abnormal destruction of red blood cells, which often points to a severe blood incompatibility between the maternal client and the fetus.
So timing is the defining factor for your exam. Physiologic after 24 hours,
Yeah.
pathologic before.
Oh.
Okay, now we arrive at what might be the most famous exam trap in all of obstetric nursing history.
Oh, I know exactly what you're going to say.
The battle of the head swellings. Cowput succedaneum versus cephalohematoma. Both present as a lump on the newborn's head, but they represent entirely different physiological events.
They really do. Let's start with caput succedaneum. This is generalized subcutaneous swelling, basically edema, caused by the mechanical pressure of the baby's head pushing against the cervix during labor.
So the fluid accumulation is located outside the periosteum, right? The dense membrane covering the skull bone.
Yes. And because it sits above the periosteum, the swelling is diffuse and can cross over the cranial suture lines. It is relatively harmless and resolves on its own in a few days.
Here is your memory anchor for this, guys. Kaput sounds like cap. Think about how a baseball cap fits on a head. Go all the way across the top of the skull. So kaput crosses the suture lines.
That is a great memory trick. Now, cephalohematoma is a very different clinical picture. Just look at the word. The word hematoma tells you this is an active collection of blood.
Right, it's not just fluid.
Exactly. It is superius steel bleeding, an actual hemorrhage occurring deep between the skull bone and its periosteum, frequently resulting from the trauma of a vacuum-assisted or forceps delivery.
And because the bleeding is physically trapped underneath the periosteum of one specific skull bone, the swelling absolutely does not cross the suture lines.
Right. It stops right at the boundary of the bone.
And because a cephalohematoma involves a large pocket of localized blood that eventually has to break down, that newborn is at a significantly higher risk for developing severe jaundice a few days later.
Exactly, because all those extra red blood cells have to be processed by that immature liver.
Right. Okay, let's look at the assessment scoring systems. The big ones are APGAR and Ballard. APGAR is a rapid snapshot of the newborn's transition performed at exactly 1 minute and 5 minutes after birth.
Yes, and it measures heart rate, respiratory effort, muscle tone, reflex irritability, and color.
But instead of memorizing the whole list, focus on how you gather this data in a chaotic delivery room. You aren't doing a slow, methodical checklist.
No, not at all. You are looking at the baby. Are they pink or blue? Are they screaming and vigorously crying, which, gives you respiratory effort and reflex irritability at the same time? Or are they silent?
Right, and are their arms and legs flexed tightly to their body, showing good muscle tone, or are they totally floppy and flaccid?
Exactly. Now, the new Ballard score is an entirely different tool. It assesses physical and neuromuscular maturity to determine the baby's postnatal gestational age.
So the nurse evaluates parameters like skin transparency, the presence of lanugo, that fine, downy body hair, the development of breast buds, and joint flexibility, like how far the baby's wrist can fold.
Right, because preterm babies have virtually no muscle tone, so their joints are incredibly flexible.
But there is a classic trap with the Ballard score you need to watch out for.
Yes. The Ballard score is notorious for overestimating gestational age. Modern technology, like an early first trimester ultrasound, is vastly more accurate for dating a pregnancy.
So why do nursing exams still test the Ballard score so heavily?
Because it forces the student to recognize the physical distinctions between a premature infant and a full-term infant.
That makes total sense.
Oh,
Okay, so we've completed the assessment, we've found the expected weirdness, and ruled out the emergencies. But the nurse's job now shifts from observation to active prevention.
right. Newborns require immediate pharmacological interventions to prevent catastrophic, life-altering complications.
And the intramuscular injection of vitamin K is a primary example.
Absolutely. Normal human physiology relies on bacteria in the gut to synthesize vitamin K, which the liver then uses to produce essential clotting factors.
But the newborn gut is completely sterile at birth, right? They haven't been exposed to the environmental flora necessary to build that bacterial colony.
Exactly. So they have an immature liver and zero vitamin K synthesis, Without that injection, they lack clotting factors 2, 7, 9X, and X.
Which means they're at a massive risk for hemorrhagic disease. I mean, a minor bump or a routine procedure like a circumcision could lead to a catastrophic bleeding event or even an unprovoked intracranial hemorrhage.
It is a non-negotiable preventative measure. And similarly, we administer erythromycin 0.5% ophthalmic ointment.
Right, a ribbon of this antibiotic is placed in the newborn's lower conjunctival sacs to prevent ophthalmia neonatorum.
Which is a severe, rapidly progressing form of conjunctivitis caused by exposure to Neisseria gonorrhea or Chlamydia trachomatis during passage through the birth canal.
And if left untreated, it causes permanent blindness.
Yes, and parents often ask to wipe the ointment out after a few minutes because, it makes the baby's vision blurry during that crucial bonding time.
But as a nurse, you cannot let them do this.
No, never. The ointment must remain in the eyes for the full recommended duration to actually eradicate any potential bacteria. Wiping it away defeats the entire prophylaxis.
Speaking of immediate interventions, the hepatitis B vaccine is routinely given within 24 hours of birth. But the exam trap here revolves around maternal status.
Oh, this is heavily tested. If the maternal client is documented as hepatitis B positive, the standard timeline is irrelevant.
Right. That newborn must receive both the hepatitis B vaccine and the hepatitis B immune globulin, or HBIG, within 12 hours of birth.
Vaccine and the immunoglobulin. 12 hours. Do not let a multiple choice option trick you into waiting 24 hours for a positive maternal history.
Got it. Let's move to the mandatory newborn screens. The universal blood screen is performed via a heel stick between 24 and 48 hours of life.
Yes, and we wait 24 hours to ensure the baby has ingested enough breast milk or formula to actually metabolize proteins.
Because this screen checks for profound metabolic, endocrine, and hematological disorders, conditions like phenylketonuria or PKU, congenital hypothyroidism, and cystic fibrosis.
Exactly. And clinically, the puncture is always made on the outer lateral aspect of the heel, never the center.
Right, to avoid hitting the calcaneus bone and causing osteomyelitis. Okay, the other critical screen is for CCHD, critical congenital heart disease.
Yes, and this one is non-invasive. We use pulse oximetry. But again, you cannot perform this screen before the baby is 24 hours old.
Right, if you do it too early, while the fetal shunts are still actively closing, you will get false positives.
And the physiology behind the CCHD screen is brilliant. You place one pulse oximeter on the baby's right hand and the other on either foot.
Oh, because the right hand receives preductal blood, right? Blood that leaves the heart before the ductus arteriosus shunt.
Exactly. And the feet receive postductal blood.
So if the oxygen saturation is significantly different between the hand and the foot, it means deoxygenated blood is sneaking through an open shunt and mixing into the systemic circulation.
You've got it. A positive screen, meaning danger, the baby needs an immediate echocardiogram, occurs the oxygen saturation is less than 90% in either location, or less than 95% in both extremities across 3 different checks, or if there is a greater than 3% difference between the right hand and the foot.
Greater than 3% difference or anything under 90%. That is pure, high-yield exam gold. Okay, so your shift is ending, but the nursing responsibility extends far beyond hospital doors. You have to prepare these exhausted, overwhelmed parents to keep this baby safe at home.
Which means tackling some intense education topics. Sudden, unexpected infant death, or SUI, is a devastating reality.
The nurse must relentlessly reinforce safe sleep practices. The baby must always be placed on their back to sleep.
Yes, back to sleep. They require a foam mattress and a completely empty crib or bassinet. No loose blankets, no pillows, no bumper pads, no stuffed animals, and under no circumstances should the parents engage in co-sleeping in an adult bed.
A baby in a wearable sleep sack on a firm mattress. Nothing else. And then, well, we have the incredibly difficult conversation regarding shaken baby syndrome, clinically referred to as abusive head trauma.
It is a really difficult conversation, but it is one that actively saves lives. Shaken baby syndrome is almost universally triggered by a frustrated, severely sleep-deprived parent dealing with an inconsolably crying infant.
Right, so the nurse must validate how maddening that crying can be. You teach the parents that feeling angry or overwhelmed is a normal human response.
And the vital intervention here is giving them explicit permission to walk away. You tell them, place the baby safely in their crib, walk out of the room, close the door, and let the baby cry while you take 5 minutes to regulate your own emotions.
That explicit permission to put the baby down is incredibly powerful. And speaking of crying, we need to correct a major misconception about feeding. Parents obviously want to feed a hungry baby, But waiting for the baby to cry is a massive mistake.
Oh, it really is. Crying is a late, desperate sign of hunger. A crying baby is physiologically disorganized, frantic, and stressed, which makes it incredibly difficult for them to latch properly to a breast or a bottle.
Right, so parents need to be taught to recognize the early, subtle feeding cues. Rooting, which is when the baby turns their head and opens their mouth when their cheek is brushed.
Lip smacking.
Bringing their hands or fingers to their mouth and sucking on them.
Exactly.
It is exactly like the gas gauge on your car. You don't wait until the empty light is violently flashing red and the engine is sputtering to find a gas station. That's the baby crying.
Right.
You want to pull over and fill up when the needle dips low and the dashboard gives you that first gentle ding. That gentle ding is the rooting and lip smacking.
That's a brilliant way to explain it. Feeding at the first cue prevents a massive escalation. And for parents choosing to provide breast milk, the nurse should heavily emphasize the immunological power of colostrum.
Right. This is the thick, yellowish fluid produced in the first few days postpartum.
It is densely packed with immunoglobulin A, or IgA, providing the newborn with vital passive immunity against gastrointestinal and respiratory infections while helping establish a healthy gut microbiome.
Finally, we must recognize that newborns process and feel pain acutely. We don't just guess if a baby is hurting, we assess it objectively using tools like the Neonatal Infant Pain Scale, or NIPES.
Yes. NIPES relies on observational parameters. You are assessing their facial expression. Are their brows furrowed? Are their jaws clenched? You look at the quality of their cry, their breathing patterns, whether their arms and legs are relaxed or rigidly flexed, and their state of alertness.
And a score of 0 or 1 indicates no pain. But as the score approaches 7, the newborn is experiencing severe pain requiring immediate intervention.
Right. And we use non-pharmacological methods like swaddling, skin-to-skin contact, or non-nutritive sucking on a pacifier, alongside pharmacological options like oral sucrose solutions or topical anesthetics for invasive procedures.
Wow, okay. We have unpacked an immense amount of physiology. If you are walking into your OB nursing exam tomorrow, here are the 5 absolute non-negotiable concepts you must remember. Number 1, dry the newborn immediately at birth. Stop the evaporation. It protects their oxygen reserves and prevents the catastrophic hypoxic spiral of cold stress.
Number 2, blue hands and feet acrocyanosis is completely normal. Grunting, nasal flaring, chest retractions, and central cyanosis are life-threatening emergencies.
Number 3, caput succedaneum sounds like a baseball cap, meaning the swelling crosses the cranial suture lines. Cephalohematoma is trapped blood that does not cross.
Number 4, the vitamin K injection is mandatory because the newborn has a sterile gut and cannot synthesize the clotting factors needed to prevent hemorrhagic disease.
And number 5, crying is a late hunger cue. Teach parents to look for rooting, hand-to-mouth movements, and lip smacking to feed the baby before they become disorganized and stressed.
Those 5 anchors will absolutely guide your clinical judgment, but I want to leave you with a fascinating physiological concept to consider as you study.
Oh, what is it?
Well, we focus heavily on the mechanics of the transition, but the newborn's autonomic nervous system continues to rapidly wire and mature based on the environment you create for them. Every single interaction matters.
Wow.
Yeah, managing the sharp pain of a heel stick with skin-to-skin contact, keeping the room quiet and warm, and teaching parents how to handle a difficult temperament without shaking the infant. These aren't just isolated nursing tasks. You are quite literally helping to wire that baby's lifelong ability to regulate their cardiovascular system, manage stress, and thrive in their environment.
The muddy waters of the delivery room are where you set the blueprint for a human's entire life. Keep this physiological deep dive fresh in your mind for your exams. Trust the science, and you will be an incredibly safe, effective nurse. Good luck.